All right, day 18, psychiatric disorders. I think it's pretty cool to think about. This is the last bit of new material you get for this term, and then it's 4 insane weeks of cardio palm, and then you're out to the clinic. So, I mean, if you don't see the light at the end of the tunnel yet, to the clinic at least, you hopefully do pretty soon. So, really excited. So let's get to this here. Like I said, psychiatric disorders. I think actually it's kind of sad that this is talked about hardly at all, and at like the very end of the term. But at least we're giving it some time now. So it's something that you're just definitely going to see of all the other disorders we've talked about, all the other pathologies. This is what you're going to possibly see the most of, really, are psychiatric disorders and a wide spectrum of those things. So there are probably 10 to 13 questions, I think, that come from this information on the final exam. So a lot of basic definitions, but also a little clinical application to how we can respond to some of these things. So psychiatric disorders are 30% higher in any rehab setting. Outpatient, skilled nursing, inpatient, does not matter. You're going to have increased psychiatric disorders. So let's look at the different disorders here. Well, like I said, I guess going back up, what does this mean to use a PTA? Well, you're going to see a heck of a lot of it. So, yeah, so like I said, be prepared. You're going to be more of a motivator, educator, and a psychologist than you are a therapist. So, physically, I guess. So, first disorder, talk about anxiety, apprehensive anticipation of future danger or misfortune accompanied by tension and agitation. So we have an example here. A panic attack is a more severe type of anxiety attack. It comes along with shortness of breath, hyperventilation, chest pain, heart palpitations, smothering feeling, thinking one's going crazy. Can lead to phobias. That's when the person feels imminent danger or death, and there is none or no reason for that. And the actual fear of immediate death. I actually have suffered from panic attacks. And the fear of immediate death is real. And I mean, I guess it definitely is reassuring once you figure that out, and that it just has to run its course, because it's a horrible feeling for anyone that's ever had a panic attack. I can definitely relate. Anxiety of any kind, whether it be panic or just general anxiety, is going to increase the pain of the patient. I don't know why there's so many people. I mean, I guess I know why, but it totally stinks that most places you go into, people are watching the news. It's like, how's that not going to increase anxiety? And I guarantee that makes all their pain worse. I love the patients who you see who, like, if you're going into their room or whatever, and they're like listening to calm yoga music or watching like kittens on YouTube. It's like, oh, guess what? They're usually in a better mood. Anxiety will also increase recovery time. It decreases concentration. It could cause the patient to make rash decisions. So, I mean, think about those. Take those 4 things and give them to any patient with any diagnosis we've talked about this entire year, or these entire past 3 terms. Give them those 4 things and see how well they do. Yeah, this happens a lot in therapy. So as a PTA, what can we do? Well, we can address the fears openly, and we should. There's no point in denying it. So we need to talk about it so we can try to remedy it. Redirect whenever, when it's needed. Whatever that stimulus is, try to lower it. Stress management techniques, definitely working on just kind of calm, mindful breathing can truly help. But seeing what other techniques that patient may have, if they have any at all, and if you have any to bring to that patient as well. There isn't any one thing fits into everyone, except maybe breathing a little bit, but just try things out. That's where you gotta have that honest conversation. And then, of course, educate about anxiety and panic attacks. There's nothing you're going to be able to do specifically as a therapist to reduce that. I mean, as directly as maybe a psychologist or something like that. But we need to let the patient know of what's going on and what we know. Next, we deal with depression, feelings of despair and hopelessness. Some key characteristics: gloom, decreased energy, and very negative views. So what do we do with this? Well, I told you, you're going to be a motivator. So you're going to motivate, you're going to empower that patient. And let's understand that if you empower that patient, it's really important that we still limit the options for someone who is in a depressed state. Giving too many options can definitely make them feel overwhelmed. So Keep it simple, make them all win-win options. So if you do empower them, it needs to be a few options. And make sure you let them succeed. I mean, the last thing you want to do is like make them fail after they finally decided to try. And of course, refer to other professionals. You do that for all of these. Depression is more common in spinal cord injuries. In women are both at a greater risk factor for depression. Other risk factors: patient already has low self-esteem, reduced social support. I mean, I literally, this guy had he had Parkinson's. He was in some not great shape to begin with, and just had a total shoulder replacement. And I'd worked with him in the outpatient clinic before, and he had his buddy, quote unquote buddy, never showed up to pick him up. It was crazy. So I took this guy home and took him to his little apartment. There was like a chair, and there was like a weight bench and a bunch of other stuff. Like it looked like a grandpa's garage. It was crazy. The guy had no support. It was pretty brutal. It was tough to leave. I mean, there's times you'll feel like, man, you just want to help so many people, but you're like, I just, there's not enough of me. So that was pretty sad. So people definitely can be really reduced in their social support. Of course, other illness is another risk factor. And of course, talk to the healthcare team about this. Got to watch and get to the professionals as soon as possible. Post-traumatic stress disorder, or PTSD. This is an anxiety disorder due to tragic events or ongoing abuse. So effects on PT, of course, if anxiety causes increased pain, this is going to have a totally chronic aspect of pain. The patient may have or show signs of avoidance and fear. And they need professional help. There's nothing you can do about this. So of course, with a lot of our veterans, you can see this happening. So that's generally a population more affected by this, but it does not have to be veterans. I mean, it's just a pretty big stereotype. It would be kids, men, women, it doesn't matter who it is. Because remember, it's not just due to a tragic event, which could be military or otherwise, or ongoing abuse as well. And it's important that we keep an eye out for that. Schizophrenia, abnormal interpretation of reality. This exists in less than 1% of the population. Men more likely than women. Some basic characteristics: delusion, disorganized speech, unkept look and appearance, and self-destructive behavior. So I know we might say, well, just because someone looks dirty doesn't mean that's schizophrenia. Of course, but this is like a next level of unkeptness that is considered destructive behavior. Self-mutilization would also be something that would fall into this. So bipolar, change in mood, energy level, activity level. It's going to bounce back and forth between times of severe joy and severe depression. So you have your manic and depressive states. 20% of these patients commit suicide, and it's very genetic. Then you have conversion disorder, sorry. This is an actual physical malfunction that the patient thinks without an actual pathology. It's super rare, but occurs in up to 14% of the inpatient setting. I only met one person that I was aware of that had this. He was probably, 23, 24, and he thought he was paralyzed. It's crazy. But the key is that you don't, you don't shove it in their face that they're fine. Like you treat the patient. And you're going to ask, well, what did you do with that guy? Honestly, I don't remember. I literally don't remember. I remember walking in and he was on a mattress on the floor, playing video games, drinking a Mountain Dew, and he had a dip in his mouth. And it was dark in there. I'm like, that's all my brain actually remembers of that situation. So anyway, because lecture isn't that long, and I love Talladega Nights anyway, and it works perfect in a conversion order, feel free to enjoy the next 90 seconds of comedy if you so choose. Let's see what we got here. This is how not to respond to conversion disorder.
It was about the third week into Kathy's weight loss battle, where
she's had a battle. It's great. More commercials. Jeez.
Her to seek the comfort of other men, because she's got to run wild. You can't keep something like that back.
Hold on, man. Hold on. You gotta tell him. No, I don't care what the doctor said. You gotta tell him now.
Ricky,
The doctor told us that we should let you work it out in your own sweet time, but Ricky, you can walk.
What'd you just say?
He's telling you the truth, man. It's all in your head.
You sick sons of bitches. I mean, you walk in that door on your two legs, all fat and cocky, and looking at me in my chair, and you tell me it's all in my head? I hope that both of you have sons, handsome, beautiful, articulate sons who are talented and star athletes, and they have their legs taken away. I mean, I pray you know that pain and that hurt.
Don't you put that evil on me, Ricky Bobby. Don't you put that on us. You are not paralyzed.
I am so paralyzed.
No.
Rough on him now.
No, he needs to know.
Okay.
He's always crying.
Tough love it is. Tough love. Wake up, idiot.
You want to know what I am? You want to see what my life is?
Don't do it.
You want to see what's going on here?
Don't you stick that knife in your leg.
And that, of course, is how not to respond to conversion disorder. So then we're going to finish up here with Alzheimer's disease dementia. You guys have heard about the mini mental test forever. This is a perfect patient-based to use the mini mental. And we will discuss this much more, not the mini mental, but Alzheimer's and dementia much more in lab moving forward today. So when we put this all together, we have what's called psychological adaptation. That is adapting to the illness to obtain an optimal state of function. And grief is totally natural, but we have to go through these stages or the phases. So we have shock, anxiety, denial, depression, internalized anger, external hostility, acknowledgement, and final judgment. So those phases must happen to reach full psychological adaptation. And as a PT or PTA, what do? We recognize that this is happening. We educate the patient on it because it's always important. Again, motivators, educators, all things that come before being a therapist, and support that patient. It's important that we are very positive, yet realistic at the same time. And that can be a fine balance that we just have to work through. So, yeah, like I said, even though this is not anything what you thought you were getting into, this is what you're going to see the most, some mixture of all of these things with every single one of your patients. So I can't stress how important it is to just keep that into perspective.